Every orthodontist learns early that moving teeth is possible, but keeping them in place is the real challenge. Retention is not an afterthought. It is not the final phase of orthodontics. It is an essential continuation of treatment. Today we will explore stability, retention, and relapse in orthodontics, one of the most clinically important yet often underestimated areas in our field. By the end of this masterclass, you will not only understand why teeth relapse, but also how to anticipate it, prevent it, and manage it. Let's begin. In orthodontics, retention is defined as the holding of teeth in optimal aesthetic and functional positions after treatment. Sounds simple, but biologically it is anything but. Teeth have memory. They have been held by bone, periodontal ligament fibers, musculature, and occlusion for years, sometimes decades, before orthodontic treatment. When we change their position, all these structures exert pressure to return them back. Retention is our defense against nature's attempt to reverse our work. Let me give you a clinical analogy. Imagine bending a branch of a tree. Even if you hold it for some time, the branch tends to spring back. Similarly, orthodontically moved teeth have a strong natural tendency to relapse. Why does relapse occur? Periodontal fibers act like elastic bands. Bone remodeling takes months to years to complete. Musculature, tongue posture, and habits continue to exert forces. Growth may change the jaw relationship after treatment. Retention is therefore not a luxury. It is a biological necessity. History of retention schools. For decades, orthodontists debated what really holds teeth in place. Early in the 20th century, opinions varied widely. Some argued that retention wasn't needed at all. Others believed only fixed appliances could guarantee stability. Out of these debates emerged four major schools of thought: occlusion, apical base, mandibular incisor, and musculature schools. The occlusion school, Kingsley and his contemporaries argued that proper occlusion was the most potent factor in stability. The logic was straightforward. If the bite fits harmoniously, teeth will stay where they are. This school emphasized intercuspation as the guardian of stability. Clinical pearl: if final occlusion is poor, no retainer can truly compensate. Occlusion is still a cornerstone of retention planning today. The apical base school, Axel Lundstrom, introduced a different angle. He believed the skeletal base, particularly the apical base, was the determining factor. If teeth were positioned beyond the limits of the skeletal base, relapse was inevitable. Think of it this way: placing a post in soft soil won't hold, it will topple. Similarly, if incisors are set too far outside the basal bone, nature will push them back. Later clinicians like Macaulay and Nance reinforced this theory, warning that arch length can only be increased within strict limits. The mandibular incisor school, Tweed and Grieve, became the champions of the mandibular incisor. Their mantra was simple: stability begins with upright mandibular incisors positioned over basal bone. Tweed, after experiencing failures in his early cases, famously retreated many patients with extractions to reposition the lower incisors upright. This concept still shapes extraction versus non-extraction debates today. The musculature school, Rogers and Hellman, emphasized muscle balance. They argue that teeth can only remain stable if muscle forces, tongue, lips, and cheeks are in equilibrium. Hellman's famous words capture this perfectly: retention is not a separate stage, but simply easing off the machinery while allowing tissues to adapt. Clinical takeaway: without harmony in musculature, relapse is guaranteed, no matter the appliance. Synthesis of schools. Modern orthodontics does not pick one school over the others. Instead, we recognize that all these factors, occlusion, skeletal base, mandibular incisors, and musculature, interact. A relapse case can often be traced back to ignoring one or more of these principles. The 9 retention theorems. Having understood the historical schools of thought, let us now explore the 9 retention theorems that form the backbone of modern retention philosophy. These theorems are not rigid laws, but guiding principles distilled from decades of clinical observation, research, and patient follow-ups. We'll move through each theorem carefully, linking theory to practice and highlighting what it means for your clinical cases. Theorem 1. Teeth that have been moved tend to return to their former position. This is perhaps the most basic, yet most sobering, reality of orthodontics. Every tooth we move is under pressure to return to its original location. Why? Several reasons: morphogenetic patterning, the genetic blueprint for tooth position; musculature, surrounding muscle forces; transeptal fibers, elastic fibers connecting teeth; Bone morphology. Alveolar bone remodeling lags behind tooth movement. Clinical example, rotated maxillary incisors. Unless we retain them, the transeptal fibers will relentlessly pull them back. Analogy. Think of moving a spring-loaded lever. Unless the spring is neutralized, it will always snap back. Theorem 2. Elimination of the cause of malocclusion will prevent recurrence. This theorem emphasizes etiology. If a malocclusion is caused by a habit thumb-sucking, lip-biting, tongue thrust, failure to eliminate the habit ensures relapse. Clinical insight. You can perfectly align a Class I case, but if the patient continues with strong tongue thrusting, anterior open bite will recur. Lopez Gavito et al. Followed open bite patients and found 35% relapse 10 years after treatment, largely due to persistent functional issues. Analogy. Correcting malocclusion without eliminating the cause is like mopping the floor while leaving the tap running. Theorem 3. The malocclusion should be overcorrected. Overcorrection is a common clinical strategy. Class II malocclusions are often corrected to edge-to-edge incisor relation, anticipating relapse. Deep bites are over-opened. Rotations are over-rotated. However, not all overcorrection is real. Sometimes what looks like overcorrection is simply temporary muscular displacement. For example, Class II elastics may posture the mandible forward, mimicking correction. Once elastics are removed, the mandible reverts. Thus, overcorrection must be true dental change, not just muscular camouflage. Theorem 4. Proper occlusion is a potent factor in holding teeth. Occlusion, once again, takes center stage. Proper intercuspation stabilizes teeth. But beware, occlusion alone is not enough. Orthodontists often blame relapse of mandibular anterior teeth on pounding of maxillary canines. Yet long-term studies show that even patients with open bite, no anterior contact, still experience mandibular crowding. Lesson. Occlusion is important, but it is not the sole guardian of stability. Analogy. A good occlusion is like a strong lock, but without the key of muscle balance and bone adaptation, the lock is meaningless. Theorem 5. Bone and adjacent tissues must reorganize. Retention is not just mechanical, it is biological. After orthodontic movement, alveolar bone and periodontal ligament fibers are stretched and distorted. They need time to reorganize. Histology shows it may take 3–12 months for full reorganization. This is why fixed or removable retention is essential in the early post-treatment phase. Some argue for fixed retainers to hold while tissues heal. Others argue for inhibitory appliances that allow micro-movement and natural adaptation. Either way, ignoring tissue biology is a recipe for relapse. Theorem 6. Upright lower incisors over basal bone are more stable. Tweed's famous principle, mandibular incisors uprighted over basal bone have the greatest chance of long-term stability. But this is not absolute. Some cases show perfect uprighting yet still relapse. The problem is defining uprights and identifying basal bone. Clinical case. Many crowded cases show incisors upright over basal bone, yet irregularity develops again post-retention. Lesson. Aim for proper incisor inclination, but don't treat it as a magic formula. Theorem 7. Corrections carried out during growth are less likely to relapse. Timing matters. Corrections done in growing patients tend to be more stable. Why? Because growth helps lock the correction into skeletal adaptation. Example. Early Class II treatment with functional appliances can redirect growth and achieve long-term stability. But beware, growth can also destabilize corrections, especially mandibular forward growth in Class III cases. Therefore, growth is both an ally and an enemy. Theorem 8. The farther teeth have been moved, the less likely relapse. Controversial. This theorem is controversial. Some argue that dramatic tooth movements place teeth into new equilibrium, reducing relapse. Others argue the opposite, more movement, more relapse risk. Clinical evidence leans toward caution. Extensive movements increase root resorption risk and often relapse. So while dramatic corrections are possible, do not rely on them for stability. Theorem 9. Arch form cannot be permanently altered by appliances. This final theorem is critical. Mandibular arch form is essentially fixed by musculature and basal bone. Attempts to permanently expand intercanine width usually fail. Arnold, Riedel, and others show that intercanine width tends to return to pre-treatment dimensions, even 10 years post-retention. Therefore, do not fight the arch form. Respect it, work with it, And do not design unstable expansions unless you plan for permanent retention. Analogy: think of the mandibular arch as a spring set at a factory width. You can stretch it temporarily, but it will snap back. These 9 theorems, when taken together, form the foundation of retention science. They remind us that teeth are not passive objects. They are living structures influenced by bone, fibers, muscles, occlusion, growth, and habits. Relapse is not mysterious. It is predictable. And by understanding these principles, we can design retention strategies that respect biology and maximize stability. Clinical evidence and case reports. We've explored the 9 theorems that provide theoretical guidance. But what do long-term studies and clinical cases actually show us? Orthodontics is not just philosophy, it's data-driven. Let's review the evidence. Intercanine width relapse. One of the most consistent findings in orthodontic literature is the relapse of mandibular intercanine width. Arnold studied patients over 5 years out of retention. He found that intercanine width often contracted back toward pre-treatment dimensions even after significant expansion. In some cases, an initial 4.2 mm increase shrank to just 0.7 mm maintained after 5 years. Riedel and colleagues followed extraction and non-extraction cases for 10+ years. Their conclusion was sobering. Long-term mandibular alignment was highly unpredictable, with less than 30% maintaining ideal anterior alignment. Crowding increased in most patients, regardless of treatment mechanics or initial characteristics. Clinical pearl. This is why many orthodontists say, don't fight the intercanine width. Respect the original form, or plan for permanent retention. Variability in post-retention. Stability Riedel, Shapiro, and Shields et al. All confirmed variability. Some patients retain alignment for decades, others relapse within a year. What predicts stability? Surprisingly little. Cephalometric measurements, arch dimensions, angle classification, extraction versus non-extraction. None reliably predict who will relapse. Shapiro noted one exception. Class 2 Division 2 cases often maintained intercanine width expansion better than Class 1 or Class 2 Division 1. The message: retention planning must be individualized. There is no universal formula. Rotation relapse. One of the most common and frustrating relapses is rotation. Teeth that were rotated before treatment almost always attempt to derotate. Why? Transeptal fibers. These elastic fibers stretch during rotation correction and exert pull for years after treatment. Strategies to manage rotation relapse include over-rotation during treatment, fibrotomy procedures, e.g. Edwards circumferential supracrestal fibrotomy, long-term bonded retainers in high-risk cases. Clinical lesson: once rotated, always at risk. Analogy: a rotated tooth is like a twisted rope. It wants to unwind unless you keep it tied. Tooth size. Discrepancies. Bolton analysis. Ballard examined 500 patients and found that 90% had tooth size discrepancies. If ignored, these discrepancies can create instability. For example, maxillary teeth oversized X increased overjet or crowding. Mandibular teeth oversized XX incisor crowding or end-to-end bites. Solutions include interproximal reduction, stripping, selective extractions, or adjusting treatment mechanics. Bolton analysis and diagnostic setups are invaluable for identifying these discrepancies before finishing. Transverse discrepancies and expansion. Relapse. Rapid palatal expansion, RPE, has one of the highest relapse tendencies, particularly in the permanent dentition. Research shows that unless expansion is overcorrected and held passively for at least 16 weeks, transverse relapse is common. Slow expansion with light continuous force, mini expanders, 2-4 psi coils, tends to be more stable than rapid force expansion. Clinical lesson: expand cautiously, overcorrect when necessary, and retain long enough for sutural bone to remodel. Axial inclinations. Another subtle yet important factor is axial inclination. Over-retracted mandibular and maxillary incisors often end up too upright, creating deep bites and functional instability. Bolton found that ideal occlusions typically showed combined axial inclinations of about 177 degrees between upper and lower central incisors. Excessive uprighting compromises function and stability, leading to relapse and even periodontal risk. Clinical pearl: always balance aesthetics with functional inclinations. Third molars in relapse. A long-standing debate: do third molars cause anterior crowding? 80s et al. compared patients with erupted, absent, impacted, and extracted third molars over 10 years. Result: no significant differences in crowding between groups. Translation: third molar removal should not be justified solely for preventing relapse. Crowding occurs regardless of third molar status. Summary of evidence. So what does the evidence tell us? Relapse is common and often unpredictable. Intercanine width almost always contracts. Rotated teeth relapse without surgical fixed support. Tooth size discrepancies destabilize occlusion. Expansion relapses unless carefully retained. Third molars are not the villains we once thought. This means retention is not optional, and long-term strategies are necessary. Growth factors and gender differences. We've seen how teeth relapse for mechanical and tissue-related reasons. But another powerful, often unpredictable variable is growth. Growth can be our ally, but it can also undermine years of careful orthodontic work. Let's look at how growth, maturation, and gender differences affect retention. Growth as an aid. Orthodontists frequently harness growth during treatment. In the mixed dentition, growth allows us to correct skeletal discrepancies using headgear, functional appliances, or anchorage mechanics. For example, cervical traction can redirect maxillary growth, restraining forward movement of maxillary molars and alveolus. Meanwhile, the mandible continues to grow forward, creating a more harmonious Class 1 relationship. Functional appliances such as Herbst or Twin Block capitalize on mandibular growth, encouraging forward positioning. In these scenarios, growth enhances stability, locking correction into skeletal adaptation, rather than purely dental compensation. Analogy: think of growth as a moving escalator. If you step on it at the right time, it carries you upward effortlessly. If you miss it, you're left behind. Growth as a risk. But growth is a double-edged sword. Latent mandibular growth can destabilize corrections. In Class 3 cases, mandibular growth after treatment often reestablishes anterior crossbite or negative overjet. This is why many clinicians delay definitive treatment until growth completion in severe skeletal Class 3 malocclusions. Even in Class 2 cases, downward or backward mandibular growth can reopen overjet and compromise stability. This is the paradox: growth helps us, but it also betrays us. Implications for retention. Because growth continues into late adolescence and sometimes into the early 20s, retention protocols must anticipate it. Particularly in boys, continued mandibular growth may destabilize incisor alignment and bite relationships. In these cases, prolonged or even permanent retention of the mandibular anterior teeth is often recommended. Functional appliances can also serve a retention role, worn at night to counteract unfavorable growth patterns. Recovery from growth. In some cases, growth itself can recover from orthodontic changes. For example, if mandibular plane angle increases during treatment, subsequent growth may reduce it again, re-establishing a deep bite. Similarly, occlusal plane rotations from Class 2 elastics may revert once elastics are discontinued and growth continues. This is why cephalometric follow-ups are so valuable. They allow us to differentiate true relapse from growth-related recovery. Gender differences. Studies by Baird, Baum, and Petratus highlighted significant gender differences in skeletal and dental maturation. Girls mature earlier. By 11-13 years, their skeletal and dental patterns often resemble those of adult women. Boys mature later, often after 15 years. Their growth continues longer, with more pronounced mandibular changes. Clinical implication. In girls, treatment must be initiated early if growth modification is desired, because the window closes quickly. In boys, clinicians must anticipate longer growth and a higher risk of late changes destabilizing occlusion. This difference is crucial in retention planning. Many orthodontists now retain mandibular anterior segments in boys until growth has clearly ceased. Clinical pearls on growth and gender. Here are the key takeaways. 1. Growth can stabilize or destabilize corrections. Plan accordingly. 2. Class 3 cases are especially vulnerable to late relapse. 3. Boys require longer retention due to extended growth. 4. Functional appliances can double as retention tools during growth. 5. Cephalometric monitoring distinguishes relapse from growth recovery. In essence, orthodontics does not end when braces come off. It continues as the patient grows. Appliances and clinical applications. Now that we understand the biological basis of relapse, let's turn to the clinical tools we use to fight it: retention appliances. These devices, removable or fixed, are the last line of defense in maintaining treatment results. Each has strengths and limitations, and the choice must be tailored to the patient's risk factors. Removable retainers. The classic removable retainer is the Hawley appliance. It consists of an acrylic base plate, a labial bow, and clasps. Advantages: durable and long-lasting. Allows settling of posterior occlusion because occlusal surfaces are uncovered. Adjustable. The labial bow can be activated to close spaces or refine positions. Disadvantages: bulky and less aesthetic. Compliance-dependent patients must wear it as instructed. In contrast, the clear vacuum-formed retainer, Essix, offers superior aesthetics and patient acceptance. It is thin, nearly invisible, and inexpensive to fabricate. But it does not allow occlusal settling. It tends to wear out or crack within 6–12 months. It provides less control of rotations compared to Hawley. Clinical pearl. Hawley is preferred when long-term durability and occlusal settling are priorities. Essix is ideal for short-term aesthetics or post-aligner retention. Fixed retainers. Fixed lingual retainers are the gold standard for maintaining mandibular anterior alignment. Designs vary: canine to canine wire bonded to each tooth. Simple 3-3 twist flex wire bonded only to canines. Advantages: 24/7 retention. No compliance needed. Especially effective for lower anterior crowding, diastemas, and rotated teeth. Disadvantages: hygiene challenge, plaque accumulation, calculus buildup. Risk of wire breakage or debonding. Requires regular monitoring. In high relapse risk cases, especially mandibular anterior crowding, permanent fixed retention is often the only predictable solution. Retention protocols: limited, moderate, permanent. Retention must be customized to the type of malocclusion treated. Jundeff and Riedel propose 3 broad categories of retention need. 1. Limited retention, minimal risk of relapse. Examples: crossbite correction. Serial extraction cases with proper eruption, minor rotations corrected early. Retention here may last only a few months to a year. 2. Moderate retention, most common category. Examples: class 1 or 2. Malocclusions with extractions. Deep bite cases. Minor spacing. Retention here may last several years, often tapering off. 3. Permanent or semi-permanent retention. High relapse risk cases. Examples: expansion of arches, severe rotations, diastema closure, severe mandibular crowding, class 3 corrections. These patients should expect permanent retention, usually a fixed lingual retainer. Duration of retention. How long should retainers be worn? This is one of the most controversial questions in orthodontics. Riedel originally recommended 1 year as sufficient for tissue reorganization, but follow-up studies showed continued relapse after many years. Many orthodontists today adopt the philosophy, retention is for life. In practice, this means removable retainers, full-time for 6 to 12 months, then nighttime indefinitely. Fixed retainers, bonded indefinitely unless hygiene becomes unmanageable. Clinical pearl. It's better to promise patients permanent retention from the beginning than to imply retainers will be temporary. Special situations. Certain malocclusions require specific strategies. Deep bite cases, use bite plates or Hawley with anterior bite plane during retention. Open bite cases, retain with posterior coverage to prevent vertical relapse. Expansion cases, prolonged retention with fixed retainer or transpalatal arch. Spacing diastema. Fixed bonded retainer mandatory, often supplemented with removable. Surgical cases, post-orthodontic patients may require long-term retention due to skeletal relapse tendencies. Patient education. No matter how well we design appliances, retention fails if patients are not educated. Patients must understand, retainers are not optional, they are insurance. Compliance is essential for removable retainers. Fixed retainers require meticulous hygiene. Retention is not a phase, it's a lifelong habit. In my clinic, I tell patients this simple rule: if you want to keep your smile, keep your retainer. Recovery, long-term changes, and conclusion. Transition to long-term changes. Even with excellent mechanics and well-designed retainers, nature continues to influence the dentition for decades. Stability is not a permanent state. Orthodontics, like medicine, works with biology, not against it. Let's look at what happens in the long term. Recovery from orthodontic changes. Several longitudinal studies have shown that certain orthodontic changes tend to recover with time. Occlusal plane rotation. Class 2 elastics often rotate the occlusal plane downward anteriorly. Years later, natural growth and function partially reverse this rotation. Mandibular plane angle. Deep bite cases corrected by opening the bite may relapse as mandibular growth reasserts its original pattern. Arch form. Despite expansion, mandibular arch width often contracts toward pre-treatment values. In many ways, this is the body attempting to restore equilibrium. Long-term follow-up studies. Riedel followed patients for over 25 years after treatment. He found mandibular incisor crowding tends to increase with age, even in untreated controls. Maxillary arch changes were less severe but still occurred. Occlusal relationships sometimes improved as teeth sought intercuspation, but alignment almost always deteriorated with time. Little's classic Seattle study reinforced this. Less than 10% of patients maintain near-perfect mandibular alignment 20 years post-treatment. Translation: some relapse is inevitable. The question is not whether relapse will happen, it's how much and how we manage it. The role of aging beyond adolescence. Aging itself affects the dentition. Tooth wear, periodontal changes, and continued eruption alter occlusion. Lower anterior crowding is often blamed solely on orthodontic relapse, but it also occurs in untreated individuals. This means we must set realistic expectations. Orthodontics cannot freeze the dentition in time. Retention manages change, but it cannot eliminate it. Clinical message. So where does this leave us? 1. Relapse is predictable, not mysterious. It follows biological patterns: fiber elasticity, bone remodeling, musculature, and growth. 2. Retention must be planned, not improvised. Hawley, Essix, fixed retainers, all have roles depending on risk. 3. Permanent retention is often necessary, especially in cases of crowding, spacing, rotations, and expansion. 4. Patient education is critical. Retention is not optional, it is lifelong insurance. 5. Orthodontics is about biology, not mechanics. We must respect natural equilibrium. Closing words. In summary, moving teeth is predictable. Keeping them stable is the real challenge. Retention is not a phase, it is a philosophy. Our job as orthodontists is not just to deliver straight teeth at debonding, but to design stability for life. Because orthodontic treatment does not end when the braces come off, it continues every day the patient wears their retainer. Understanding these methods is key to appreciating the science and artistry behind creating beautiful, healthy smiles. Thanks for watching, and we hope this video has helped you better understand this vital aspect of orthodontic treatment. So, the next time you see a stunning smile, you'll know the incredible science and artistry that may have gone into creating it. If you're a student interested in dentistry or orthodontics, we hope this video has given you a glimpse into this exciting field. Don't forget to like, subscribe, and hit that notification bell for more educational content. And if you have any questions, drop them in the comments below. Thanks for watching.